and I hope you can see me. I hope you can hear me. If you can, please leave me some comments below. Could you please say your name and say which country you're from so that I can get a real sense of which students we're reaching? So the whole point of the anatomy clinic was to give you a chance to ask questions that perhaps we hadn't thought of on topics like us to cover. And while we're waiting for people to join in, what I thought I'd like to do is just touch on a topic that we have been thinking about, or that I've been thinking about, and that is about belief systems. Because when you're studying, there's a lot of negative thoughts that enter your head. And I know that this can be quite difficult, particularly at a time during coronavirus. And I wanted to kind of make you think about where your belief systems come from. Now, beliefs are some things that you hold to be absolutely true, and you know for rock solid, you believe in this. And quite often our belief systems actually come from our upbringing, from our parents, from our culture. And they affect everything. They could affect how we live, the type of religion we have, the type of culture we have. And to give you a small example, take eating. So eating is something that we do on a regular basis, and but different cultures have different ways of eating. So, for example, in the Japanese culture or in the Chinese culture, they use chopsticks and they believe that that is absolutely the right way to eat. Whereas a different culture may think, well, why on earth would you use sticks to eat? It makes no sense. You pick things up and they just drop straight away. In the Indian culture, this is the culture that I'm from, people eat with their hands because they like to feel the food, and it's a very tactile experience with food. But for people from the Western culture, they think, ew, why would you want to eat with your food? Why with your hands? Whereas for somebody who's used to eating with their hands, if you can't eat with your hands, they say, well, that just didn't work for me. It didn't feel like I was eating properly. The food tasted different. In the Western culture, we eat with knives and forks. And I know that when I was a little girl and we went back to India, they'd be like, oh, look at her, she's eating with a knife and fork. And that seems such a bizarre thing to do. And that's just with eating. So one of the other things that people believe in is they have beliefs about themselves. And one of the beliefs that they may have about themselves is things that they've been taught from a young age, from a childhood. For example, if you come from a large family, say of maybe 3-4 people, quite often you get labelled as a certain type of person. For example, if you are perhaps shy, your family may have said, oh, this is so-and-so, she's the shy one, or this is so-and-so, he's the sporty one. And that label gets put there and it gets repeated again and again and again, and you kind of start to believe that. But here's what I would like to ask you to do. Have a think about what labels you have been given, and if you were to describe yourself, what words would you use and why? And once you make that list, what I'd like you to do is think, well, is that actually true? Is that me? Am I that person? Or has that been a label that somebody has given me and I've now just believed it and I've gone on with it? And the reason for doing this is when you are studying, when you are learning to be whatever you're going to be in the future, your beliefs and what you believe and who you think you are absolutely has an influence about how you interact with other people, how you study. And my job here at the Funky Professor is not only to teach you some anatomy and teach you the clinical relevance of anatomy, but also what I'd like to do is to give you the confidence, to give you the self-belief, to give you the motivation that you can do your course. Because here's the thing, if you have got onto your course, you are more than clever enough to stay on your course. You will not fail this course because you are not clever enough. This is really important. People fail or people don't complete courses for completely different reasons. And one of them is their lack of self-belief, and the lack of motivation. And what we want to do here today is start this process of getting you to believe in yourself that you can do this. And one of the things that helps along the way is to find out, well, who are you actually? So your homework over the next week, if you can, until I see you next week, is to have a really good think about, well, okay, well, what do I believe about myself? And then I want you to be very, very clear about, do I actually believe it? Is that true? Is there evidence for that? Do I believe that? Right, that being said, I'm going to say hello to Destiny Girl from Nigeria. I'm saying hi to Sachin from the Ukraine, Akhil, and there's a few more people who've joined us on Instagram. If you are joining us on Instagram, please could you... Oh, there's Jay from India. Hi, Jay. And if you are on Instagram, I am going to start the part now where we're going to do anatomy. And I've actually done a PowerPoint presentation, which I'd like to share with you. So this is now on YouTube. So go to our YouTube channel, The Funky Professor, and you should be able to stream it live. Somebody's just joined me from the Philippines. How cool is that? Hello. And we should be able to start off with our anatomy section. So, I was given 2 questions this week, so 2 requests. One of them was, could they cover Nagapriya? This is for you. This is your question. So one of the questions was about the flexor tendons. So we're going to kick off with that. And we're going to talk a little bit about the flexor tendon, the anatomy, and we're also going to talk about the clinical relevance, because you need to understand why you're studying this, right? I mean, you could be studying this all day long, but if you put it into a clinical context, you suddenly go, oh, okay, that's why. So that being said, let's kick off with the flexor tendon sheath. So the flexor tendon sheath are these tendons that come into your fingers, into your thumb. And there are 2 key tendons that I want to talk to you that attach to each finger. So one of them, there are 2 bones in the forearm. There's the radius, and the radius has got the round head. So round means radius, so that's a good way to remember the radius. And the ulna, which has a U shape to help you remember, that's the ulna. Now there is a tendon that comes off it and is illustrated here, which is the flexor, means it flexes, and flexing means folding, so that helps you remember that movement. So anything that folds is flexing. So flexor digitorum means it's going to the fingers, and profundus, which means profound, it's deep. So it's got a long, slender tendons that go and attach all the way down to the tip of the finger. So one of the ways that I remember it being attaching at the tip is because it's deep, it's profound, it goes further. The other tendon that is involved in the long digits of the finger is the flexor digitorum superficialis. So the flexor digitorum profundus is in the deep compartment of the flexor compartment of the arm, whereas the flexor digitorum superficialis, no prizes for guessing, that is actually on the in the superficial compartment. If you are on YouTube, could you give me a thumbs up, because I need to know if you're still with me, if you're still following this. It would be super helpful if you could. Now, both these muscles, they're quite big muscles, start in the forearm. Now, the flexor digitorum profundus, the deeper one, actually has a really interesting innovation, because it's not just from one nerve, it's from 2 nerves. So the lateral part, which is the index and the middle finger, are supplied by the median nerve, and the medial part, or the ulnar part, is actually from the ulnar nerve. Now they form these lovely long slender tendons that go on to insert onto the fingers. So the superficialis, the tendon actually splits, it splits into 2, and it inserts into the middle phalanx. Oh, I got a thumbs up, that's great, thank you so much. Whoever did that, that really means a lot to me, because I know you can hear me. Whereas the profundus, the profound tendon, inserts onto the tip, onto the distal phalanx. So let's look at that in a bit more detail here. So I've highlighted in green the tendons, which are the superficial tendons, which you can see they split and they insert into the middle phalanx. And then further down, my next slide, if you're following me on YouTube, please, if you're on Instagram, please come onto YouTube. You should be able to see it here. You can see a tendon splitting beautifully and inserting onto the middle phalanx. I've now highlighted in pink the flexor digitorum profundus, which is inserting onto the tip. Now, another way, and a really cheeky way to remember that this is the profundus, when you're picking your nose, if you want to get your finger in there, have a good old scrape and a good old pick, you need to be able to bend the tip of your finger to really pick it. So P, profundus, P, pick your nose. Now, the thing about these tendons, if you imagine you've got a tendon starting here and it's inserting here, if you were just to pull it, this tendon would come off and it wouldn't be very efficient. So we need something to hold it in place. So there are a number of structures that have been developed for the specific purpose of holding it in place. Firstly, I don't know if you can see this here, there is a blue structure which sits, well, I've highlighted it, it's not actually blue. There's a structure which sits across the carpal bones or the wrist bones, and this is the flexor retinaculum. And these hold down the flexor digitorum profundus tendons and the flexor digitorum superficialis tendons, and they keep them nicely in that canal. But it gets better than that, because as you get to the fingers, there's a whole system of tendons that hold a whole system of arches, of fibrous arches that hold the tendons in place. And I'm going to show you these here. So you could call these, there are several of them. There's annular, they're called pulleys. So they're like little arches that hold the tendon in place. So there's ones that go straight across, and these are called annular, and there are 5 groups of these. And there are also crisscross ones, which are called the cruciate ones, cruciate pulleys. So there are 5 annular pulleys labeled A1 to A5, and 3 cruciate pulleys labeled C1 to C3. So A1 and A2 are next to each other. Then you get a crisscross, another A3 annular pulley, crisscross, and then A4, final crisscross, and then right at the tip there you have A5, holding that profundus tendon in place. So in addition to the tendons, there is another structure which is called the synovial sheath. Now, the synovial sheath of the flexor tendons are quite interesting, because there's one which goes from the wrist to the thumb, which you can see on my slide here. There's also one which goes from the wrist and it extends up to the little finger. So it's quite big. So it goes from the wrist all the way up to the little finger. And then the final one is there are 3 individual ones which go into the index, the middle, and the ring finger. So if you look at these, you can see that there is a direct communication from the wrist to the tip of the little finger. And I will just show you that once more. And here you can see the sheath and the pulleys overlying it. And so a reasonable question to ask is, so what? Well, if you were to get an infection in your finger, it spreads really quickly, super quickly. And in fact, you need to be on this, because if you don't spot it early enough, it can cause incredible damage and really affect the function of your finger. So how do you tell this? Well, there are some signs that you can look for. Carnarvon signs. You get this sausage sort of swelling, a fusiform swelling, we describe it, which is along the entire finger. And patients come holding the finger slightly bent. And it's painful. If you press it, it becomes quite painful. And if you try and extend that finger, that too becomes quite painful. So those are the signs of infection. And I got some clinical photographs here. Here you can see there's a nasty infection there of the index finger. It's held in flexion. It's swollen, looks pretty yucky. And if you try to straighten that finger, that's going to be pretty painful. And here's another one here. This time it's the ring finger, just to give you that example of what it looks like. So that is the reason why we have the pulleys, to prevent the bowstringing, and also what could potentially go wrong in an infection and what signs to look for. So I hope that has answered that first question. If you have any questions, either on Instagram or YouTube, please do. I'm just going to see if I can flick over to see if there are any Questions so far? No questions, but I'm getting thumbs up, so that's good. I think that means that people can hear me. There's Vibhai from, I'm not sure where he's from. Jarin from Bangladesh, lovely to see you. And Sandra, I'm not quite sure where you're from, Sandra. Put it in the chat so that I can see you, and let me know if this is the sort of thing that is helpful to you. So the second question, I got a hola. And this next question, I was asked to talk about the middle ear. And I thought, okay, fine, middle ear. It's been quite a while since I studied the middle ear. And when I looked at it, I thought, crikey, no wonder people are confused about this. But luckily, one of my best friends happens to be an ENT surgeon. His name is Dr. Robert Harris, who's an ENT surgeon at St. George's Hospital in London. And he's very kindly agreed to come and give us a lecture about this on the 3rd, I think, of February, in 2 weeks' time. On the 3rd, not next week, 2 weeks after that, 3rd of Feb. The way he describes it is fantastic, and he talks about the embryology, which completely made it was my aha moment. Okay, so that's why it is the way it is. But not to keep you in suspense, I'm going to give you my version of the middle ear to tell you what you really need to know, and just a little teaser for Mr. Harris's talk in a few weeks. So the middle ear, this is what you need to know. And it's very easy to get bogged down in all the details of the middle ear because there are a lot of structures in there, there's a lot of nerves in there, but keep it simple, okay? So the middle ear is in this bone here. So this is the temporal bone, and I've highlighted it now in green so that you could see it. And the thing that struck me about the temporal bone, which is quite useful, I think, for you to appreciate, is if you take the anterior view of the facial skeleton, here's the anterior view of the facial skeleton, and you here, and you remove the zygomatic bone, now you can see the temporal bone, and what sits right above it is the brain. It is so close. It is incredibly close to the brain. And I hadn't really appreciated that before. And that's something useful to bear in mind as we talk about the description of the contents of the middle ear. So this is now, if we remove the bone in isolation, this is the temporal bone. And here there's a hole. And this hole is the external auditory meatus, or the opening into the bone. This now is the anterior view. So if you can see here, this is the skull with the maxilla and the zygomatic bone removed, and then you can see the temporal bone here. There is a couple of holes directly communicating it with the brain, and we're going to talk about that in a second. But the ear, the real juicy bits, the mechanics of the ear are in there. And so here is that again, and here you can see a nerve going in. This is the facial nerve, and the branches of the facial nerve coming out, rather, and it's in there. Let's try and grey that out for you a little bit further. And there you can see now some of the components of the inner ear, which is the cochlea and the semicircular canals, which we'll come on to. And I've put in here and highlighted in green, these are the ossicles, or the bones of the inner ear. If you're watching this on the Instagram and you're a bit confused, hop over and join us on YouTube, because you'll be able to see it much more clearly there. So let's take a slice through the ear and let's see what we can find. So the outer bit is the pinna, this is the bit that you can see. And here you've got the ear canal coming down to this structure here, and then the middle ear. So up to there is called the outer ear. This zone here is the middle ear, and this zone here is the inner ear. So you have three main parts: an outer ear, a middle ear, and an inner ear. And let's focus a bit more on that. Now you can see a bit more clearly the middle ear with the three bones, and the inner ear. So this is just to show you the outside of the bit that you can see, the outer ear. So let's take a look at this. This is demonstrating the outer ear with the canal in the sort of purplish one, the section from the tympanic membrane, which is the eardrum, to give it its common name, and beyond the eardrum is this air-filled cavity which houses the three bones, and beyond that is the inner ear. Now, when you look at the inner ear, but there are three bones, and they are teeny tiny. They are so tiny. They're tiny. They're like a tiny little SIM card that you would put into your phone. SIM card, SIM. Bingo, because that's the mnemonic that you need to remember the three bones. SIM, S for stapes, I for incus, and M for malleus. Now, we mentioned that there is a drum, the tympanic membrane, which is like an eardrum. Well, what do you need to bang a drum to make a big sound? You need some drumsticks, or you could bang it with a big hammer. And another word for a hammer is mallet. And the bone that bangs on the eardrum is indeed the malleus. So that helps you remember that bone. The incus is anvil shaped, which is why it's called the incus, because that's anvil. And the stapes, when I looked at this is a phenomenal looking bone. It is exactly like the stirrup. Now, if any of you have been horse riding, when you sit on a horse, you have a saddle and you put your legs into stirrups to be able to control the horse, to be able to kick the horse. And stirrups is stapes. So that helps you remember that. So with the malleus, you bang on the eardrum, and with the stapes, you kick the oval window. So the whole purpose of the ear is to take sound waves and convert them into electrical impulses that can be transmitted to the brain, and the brain can process this and understand this as sound. Because if we didn't have a middle ear, these three bones which are amplifying the sound, concentrating the sound, we would not be able to hear efficiently. So this is just a genius of bioengineering that they've come up with this design. And Dr. Robert Harris, as I said, will talk to us a little bit more in a few weeks about how this evolved. But for now, what I want you to remember is that as sound waves come crashing in, the eardrums going backwards and forwards, banging on that malleus, which causes a chain reaction down the incus to the stapes, and the stapes is banging on the oval window, so that causes a further reaction in the inner ear. And we'll come on to what happens in the inner ear in a second. Now, for those of you who have looked at the anatomy before, this is a very common diagram. You can find it in your Gray's Anatomy books, which there's a student version, which is very useful. So we're now looking into this as a box or a cube, and we're looking as though we've buried ourselves into the ear, and we see a number of important structures here. The bones of the inner ear have been removed, so you can see that this. I'm just going to go back, actually, I beg your pardon. What you can see here is in the inner ear, very closely to it is the cochlea, which is the round part here, and the semicircular canals. You can also see coming in is this structure here, which is the facial nerve. So the facial nerve sort of comes through it. And